You're listening to Medscape's In Discussion series on Cardiorenal Metabolic Syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today we're discussing LDL cholesterol, dyslipidemia, and lipoprotein a. I'd like to welcome today's expert guest and my very close friend and colleague, Dr. Seth Martin. Dr. Martin is a professor of medicine in the Division of Cardiology at Johns Hopkins School of Medicine, specializing in preventive cardiology, lipids, and digital health. He's a core faculty member at the Ciccarone Center for the Prevention of Cardiovascular Disease, where he directs the Advanced Lipid Disorders program and co-directs the Digital Health Innovations Lab. In addition, Dr. Martin serves as director of the Johns Hopkins Center for Mobile Technologies to Achieve Equity in Cardiovascular Health, which is part of the American Heart Association strategically focused research networks on health technology and innovation. Seth, thank you very much. I want to welcome you to the Medscape In Discussion podcast.
It's a pleasure to be here. Thank you so much, Nihar.
So, Seth, I couldn't have asked for a better person to kind of, help us and the audience think about LDL, dyslipidemia, lipoprotein a in the context of our cardiorenal metabolic patients. We've already had lots of discussion around prevalence of CRM, what's going on in terms of social determinants, all the things that come together for these patients. And now we're going to kind of dig into some of the key therapies and some of the key clinical comorbidities that manifest in these patients. And so as we kind of focus on cholesterol, dyslipidemia, and kind of related topics, I thought we'd start with LDL cholesterol. We've obviously been talking about LDL for a long time. Your work has been instrumental in kind of guiding and shaping the field as we think about optimal management of LDL cholesterol. So maybe we'll start there, Seth. Where are we on LDL cholesterol? What's the right LDL cholesterol that we should be aiming for? And how do you think about LDL in the context of our cardiorenal metabolic patients?
With LDL, it is something where I feel like we have such strong evidence now, and it's basically an implementation challenge. We have multiple therapies, combination therapy is increasingly used, but yet many patients at risk are not receiving the therapies that are recommended by guidelines and available to them. The saying has come now with respect to LDL that lower for longer is better. We've learned that the risk is tied to the cumulative exposure to LDLs, and that going to very low levels, there's a monotonic relationship between LDL and cardiovascular risk. So the lower we go, the better. It's the garbage of lipid metabolism that we want to get rid of. And so we want to start as soon as possible because that's going to get us to the goal as soon as possible. And then we want to keep the LDL low as long as possible. And so we have a rich armamentarium of therapies now. If I think back to going to some of our cardiology conferences not that long ago, and it was all about statins. And there was unfortunately a failure of a number of lipid therapies to improve upon statins. And then we had the Improve It trial come out with ezetimibe, and then we had the PCSK9 trials, and now we have bempedoic acid. We now have a rich armamentarium, and it's an implementation challenge that I think we're facing. But it's a really good problem to have because our patients can benefit with reduction in heart attacks and strokes, about a 25% or so a reduction in the relative risk for every 40 milligram per deciliter lowering of LDL. So where do we want to be going with our very high risk patients or with patients with cardiorenal kidney metabolic disease? The lower we know is better, but practically speaking, in the secondary prevention space, we want to get at a minimum below 70. But in many patients who are very high risk, we want to go below 55. So we can talk more about maybe some of the patient profiles, where we'd want to go more aggressive than others. But I think we're in a really exciting time, Nihar, because we have such effective therapies, and now it's a matter of fine tuning our approaches on the front lines and scaling up our implementation efforts.
Yeah, terrific, Seth. Thanks for kind of laying the broad foundation here. And I couldn't agree with you more. It's a very exciting time in terms of LDL cholesterol. There's so much that can be done. We've learned so many things, and so many therapies have now come to the forefront. And there is this big question around implementation and how we bridge the evidence practice gap. But I want to sort of stay with you for a moment on you. Let's think about the cardiorenal metabolic patients that we're going to see in our office, tomorrow or next week when we're kind of in the ambulatory environment. Is the distinction kind of between primary prevention and secondary prevention, is that still the right framework for us to be thinking around? I know there's been a lot of back and forth about LDL goals and LDL targets and LDL thresholds. Maybe give our audience your best summary on, hey, is there a number or a range that we should be thinking about for the primary prevention, maybe the CRM patient that has diabetes and obesity, but hasn't yet had a cardiovascular event, or maybe someone that has, CKD and maybe he's already had an MI or a stroke. I mean, those are very, very different profiles of patients. And so, how do we think about within this broad term of CRM? How should we think about kind of the best or appropriate LDL?
Yeah, absolutely. I mean, it is a slam dunk when somebody already is clearly in the secondary prevention space, has had an ASCVD event, and having kidney disease is considered one of the additional risk factors that would push you into the very high risk category in that secondary prevention setting. So many of the patients will qualify strictly based on HAACC guidelines for going for LDL less than 55. It's trickier in the primary prevention setting. This is where we see some difference between our US guidelines and guidelines from elsewhere in the world. Because lower is better, and many patients with kidney disease have a number of related risk factors, and even if they haven't an event, very likely are at quite elevated risk for ASCVD. Generally, I would feel going for an LDL less than 70 is perfectly reasonable as sort of a bare minimum in terms of what we view as the goal. A more directed strategy to assess risk could take into account subclinical atherosclerosis. Many patients with kidney disease have already had a non-gated CT scan for whatever reason. And so looking at the burden of coronary calcification could be an indicator that this is somebody who already has a moderate or more severe amount of coronary calcification that would justify more aggressive LDL lowering therapy. But if not, you could consider doing a coronary calcium score to further assess cardiovascular risk to justify an even more aggressive strategy. You did mention the terms target versus threshold versus goal. I want to quickly address that. The traditional terms we had talked about, LDL is the target. It's the primary target of therapy. Non-HDL, ApoB are other targets of therapy. But traditionally, we had a goal. We want to get below a certain level. This may seem like semantics, but I believe it does also have some real implications that we've transitioned to this term of using thresholds. And the value in that is that clinical trials were designed around if you're above a certain level, you qualify for therapy. And so a threshold acknowledges that design of the trials, as well as the importance of engaging in shared decision making with the patient around what their options are. And then ultimately, if we get well below that threshold or that number, it's not that we just want to barely get below a goal, but the lower the better. So that's just sort of a starting point for discussion around intensification of therapy.
We've spoken in prior episodes in this podcast series just about the rising prevalence of CRM conditions, the high risk that many of these patients have for not only adverse cardiovascular events, but renal events, and obviously other metabolic and endocrine effects. And so clearly, LDL and optimizing LDL has to be an important part of the broad approach that we take for these patients. And so I guess I might just ask you quickly for the audience, maybe give us a sense. I think everyone's relatively familiar, obviously, with the statins, and they've been around for a long time. But as you kind of think about the PCSK9 inhibitor monoclonal antibodies, then maybe bempedoic acid, and then inclisiran, do you want to maybe just give the audience your thoughts on where we are in terms of those classes of therapies, and then what might be particularly relevant in terms of the CRM patient or for the practicing clinician out there?
We're very fortunate to have this armamentarium therapies for the patients with kidney disease. Sometimes their LDL is not that bad. It's in a more mild to moderate elevated zone, and a combination of statin and ezetimibe could be a good way to go. The SHARP trial was one of the early trials to show the use of ezetimibe in combination with statins and the benefits with that, although there was not a placebo control for the ezetimibe arm in that trial, but that was still an early indicator. So that is a can be a commonly used regimen. But then many patients also will require additional LDL lowering to get well below the thresholds, whether it's a 70 or 55 that they're using. PCSK9 inhibitors, the monoclonal antibodies, evolocumab and alirocumab, can provide at the full doses a 60% LDL lowering in the single dose of evolocumab or in the full dose of alirocumab. Inclisiran can provide almost that amount in the 45-50% range. The PCSK9 monoclonals are injected every 2 weeks versus every 6 months with inclisiran. And many patients that are highly motivated to reduce cardiovascular risk have been very amenable to injectable therapy. For those patients that prefer to stick with an oral strategy, we have bempedoic acid as another option, which can come in a fixed dose combination pill with ezetimibe. Bempedoic acid adds a 20% LDL lowering on top of ezetimibe. The fixed dose combination would give a 40% additional lowering. So we really have robust options such that virtually everybody, if we really are aggressive and use everything at our disposal, virtually everybody could get down to optimal LDL levels. Now, we do run into some prior authorization access challenges, but short of that, it really is a case where everybody virtually can get to where we want to be.
Yeah, it's great, Seth. I think your point is so well taken. I love the pragmatic approach that you kind of take and outlined for our listeners around the use of obviously statins as kind of the cornerstone of therapy. And then between zetamide, the PCSK9 inhibitor monoclonal antibodies, inclisiran, and bempedoic acid, it's really kind of finding that right combination, if you will, that's going to get that patient to the appropriate LDL. And that's also going to work for them. And so I think developing and designing a pharmacologic regimen for LDL, obviously in addition to lifestyle and all the other things that we of course advocate for. And again, given the different options that we have available now, it's a really exciting time because I think we can find that right pharmacological combo that's going to work for most of our patients and get them to the appropriate LDL. So, Seth, that was a great discussion on LDL. I might switch gears a little bit now because oftentimes for our cardiorenal metabolic patients, especially maybe the renal metabolic patients, those that have an important contributor in terms of chronic kidney disease, albuminuria, and then metabolic diseases like diabetes and others, it's often not just LDL, but it's just as much maybe the triglycerides. And so maybe give us your thoughts and your sense on where are we on triglycerides? What have we learned thus far? How do you manage triglycerides? And then, what are you kind of excited about in terms of the future when you think about triglyceride lowering?
Yeah, absolutely. So it very much we often are seeing the elevated triglycerides as a mixed picture in these patients, often in the more moderate zone, but sometimes severely elevated. First of all, I define severe hypertriglyceridemia as 500 milligrams per deciliter or more. Anything below that in the more mild to moderate zone. But it's very commonly seen, certainly in the population of patients with kidney disease, with metabolic conditions like prediabetes and diabetes. When it's in the severe zone, I say this is something that clearly needs pharmacologic intervention right away. Typically, a combination approach, including fibrates, omega 3 fatty acid therapy, along with the statin therapy. I rarely use niacin. That is also another option, but certainly the fibrates and omega 3 fatty acid therapy on top of statin are really key options. And then generally, I find that these patients need very close attention to their, if they have diabetes, to their diabetes management, because often the patients that are having the most trouble with triglycerides, their diabetes is not under adequate control. And this is where certainly lifestyle is the foundation of therapy and can help lower LDL, sometimes substantially, often more modestly. But with triglycerides, it can make an enormous difference for some patients, particularly those starting at the high end of the spectrum. If they're drinking lots of sugary beverages or they've become very sedentary, there can be big room for change, and that change then can be a key part of their triglyceride management. With the patients that have triglycerides below 500, those lifestyle strategies, even more so for me, they're important in everyone, but it would be more the starting point. But of course, in that zone, that's where the reduce it trial was with icosapent ethyl. So that is an option for those with persistent hypertriglyceridemia to add icosapent ethyl for ASCVD risk reduction in the secondary prevention setting or in other patients that are at risk in this CRM group with diabetes and so forth. And Nihar, just to briefly address your last point around exciting emerging evidence. So we've just now seen multiple exciting kind of trials presented using ApoC3 inhibitors, and we're seeing strong triglyceride reductions as well as reduction in risk of pancreatitis, which I wanted to mention that that's part of their need for aggressive treatment in those with triglycerides above 500 is the prevention of pancreatitis, not only cardiovascular risk reduction. Frankly, we still have a lot to learn around how lowering triglycerides translates into cardiovascular risk reduction. Although the Reduce It trial saw a cardiovascular risk reduction, it didn't look like that was strongly tied to the TG lowering in that trial. So that's where this emerging evidence around ApoC3 inhibitors that could be part of what we learn from that story. We have such a clean and beautiful story with LDL. We don't have that with triglycerides when it comes to ASCVD risk reduction. And so that's what I am anticipating we will learn more in the years to come.
Yeah, great, Seth. And I think there's again so many clinical pearls in what you just spoke about. And so it sounds like if the triglycerides are above 500, that deserves to be almost a primary focus for intervention. We got to do what we have to do because, again, of the risk of pancreatitis and other complications that come from that. Outside of that, for our CRM patients, we've got some evidence for the omega 3 fatty acids like icosapent ethyl, and then a lot of emerging therapies, which again just highlights how prevalent hypertriglyceridemia is, or mixed hyperlipidemia is in our CRM patients, and just what an unmet need continues to persist. That we haven't had the kinds of improvements in cardiovascular outcomes if for many of those therapies that we might have otherwise expected. And so it's nice to see that that continues to be an area for therapeutic development because we certainly see that clinically for so many of our CRM patients. So Seth, we've talked a lot about LDL, a great discussion on triglycerides. I'm going to take us maybe to an area that is just emerging, but likely will be one that we spend a lot more time talking about. At least, I think we all hope that. And that has to do with lipoprotein little a. And so I was hoping that you might be able to give the audience a very brief primer on what is LP little a, what do they need to know about it now, and what's on the horizon with regard to LP little a.
LPA is an inherited atherogenic lipoprotein that is quite prevalent around the globe. depending on where you draw the cut point, it's about 1 in 5 people that have elevated lipoprotein A levels, and those levels are largely genetically determined. There is some biologic variability over time in LPA, maybe upwards of around 25% over time in LPA, but largely the levels are genetically determined. And what's been documented very clearly now in the epidemiologic literature is that the higher your LPA goes, the higher your ASCVD risk is, as well as your risk of aortic valve disease. That's also been shown to be a causal connection through Mendelian randomization analysis. The levels of LPA vary across race and ethnicity. However, in each racial and ethnic group, as the levels go up, there's a similar monotonic increase in cardiovascular risk. So LPA clearly is an important biomarker and risk factor that is inherited, and so it can explain familial clustering of cardiovascular risk. So in families that have had excessive amounts of premature cardiovascular disease and aggressive courses of coronary artery disease, LPA may be part of the explanation for that. And it may have particularly strong interactions with other cardiovascular risk factors like smoking, for example. And so we're learning a lot around its risk. And now the evidence and the story have built to the point that we now have very effective interventions at lowering LPA in development. So what we know now is that LPA can be robustly lowered using new pharmaceutical agents, and there's multiple agents from different companies at various stages of development. The two that are furthest along are in clinical outcome trials, the Horizon trial and the Ocean A trial. And so when we get the readout from those trials, we're going to know for sure whether this will be an established target for prevention of cardiovascular disease. So we're all kind of keeping our fingers crossed that it's going to work out and we'll have a new effective option that would be applicable for many people around the globe.
No, thanks, Seth. It sounds like, yeah, we've all got to stay tuned for what comes from those clinical studies and how we think about LP little a in terms of our clinical care for our patients with cardiorenal metabolic conditions and, obviously our cardiovascular disease patients at large. One final point I'd like to get your comment on is there's been some very interesting, I think, discussions about how we should be screening for LP little a. And I think different professional societies and different groups have advocated for different things. The European based groups have really advocated for universal screening, even going back a couple of years. I think the American based professional societies are still working through that. And I think we're all eagerly awaiting that. But I will say the National Lipid Association recently put out and updated their scientific statement that also advocated for one time, or at least one time, universal screening, if you will. What's been your approach for that? How have you guys integrated that into your own prevention practice and your own clinical decision making? And what might you say to the audience, with regard to testing?
Personally, I've personally checked my own LPA. My wife's checked her LPA, and in my clinic, I routinely check it for our lipid program. It's just part of the intake labs that we do on patients as they come into our program. So we routinely check it. Now, I realize though that although there are calls for universal testing, we're far away as a kind of a health system, as a country, as being able to implement that. Right now we're in the single digit percentages in terms of patients getting tested. So although I respect the calls for universal testing, it does seem that we need to also take some prioritized approaches. And I think the CRM population, patients with kidney disease, metabolic disease, who are already at elevated cardiovascular risk, and LPA could compound that risk, I think would be a high priority population to test in. I would also, again, point back to cases where there's a family history and that may be partly unexplained. That would be another group that it's really makes a lot of sense to check an LPA. So I think we're going to see a lot of testing in the years to come, particularly if these trials pan out the way that we hope. But we're still at just past the starting line when it comes to getting going on the race for LPA testing. But I wanted to certainly advocate for it and say that I've done it in my clinic, and we find it to be a useful part of the care we provide.
Well, thank you so much, Seth. This was an incredible discussion. We covered LDL cholesterol, dyslipidemia, triglycerides, lipoprotein little a. Couldn't have asked for a better guest to join us. So, Seth, thank you so much for that. I will also just say, for the audience to please take a moment to download the Medscape app to listen and subscribe to this podcast series. Thank you again for joining us. This is Nihar Desai for the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.